articular cartilage defects, it's still the perennial challenge for any orthopedic surgeon, isn't it? Especially when you're dealing with a young symptomatic patient.
It is.
We get so focused on managing their immediate pain, but underneath it all, we know we're working with tissue that has this notoriously limited, often, non-existent ability to heal itself.
That's exactly right. And it forces our hand. We have to intervene. But the decision tree, well, it's complex. You're looking at a whole spectrum of treatments.
Yeah.
Everything from the simple marrow-stimulating techniques, your microfracture, your subchondral drilling, which, they really just rely on the body's own, frankly, poor repair capacity. And then you move up the ladder to transferring tissue. You've got autologous options like OATS or ACI. And then finally, the focus of our deep dive today, osteochondral allograft transplantation, OCA.
Okay, let's really unpack this clinical situation. We have this mountain of evidence, a whole menu of options, but I think our mission today has to be understanding why OCA, which is, let's be honest, a logistical nightmare.
It absolutely is.
Why it's so often considered the undisputed gold standard for those large, high-demand chondral or osteochondral defects. Anything over 2 square centimeters.
Well, we have to define what we mean by gold standard. Yeah. It's earned that label because it is the only viable technique that reliably restores viable hyaline cartilage right out of the box, along with the necessary subchondral bone support.
That's the key distinction.
That is the critical biological and biomechanical distinction. And to really get it, we have to understand the logistical hurdles, that ticking clock on expiration, and the rigorous biology that underpins the whole decision.
I think we need a good analogy to frame this whole decision process. So if a young patient comes into your clinic, major defect on their femoral condyle, their main weight-bearing surface, how do you conceptualize the different repair strategies for them?
So let's use the road analogy. It translates so well to load-bearing surfaces. So you've got a major structural failure in the road, microfracture. That's the road crew showing up with a bucket of the cheapest, fastest patch asphalt they can find. It's a rush job. It's fibrocartilage, not the original high-grade paving material.
It fills the hole, but that's it.
Fills the hole, but everyone knows it's going to crumble under heavy traffic.
And what about autologous chondrocyte implantation, ACI, where we're growing custom cells from a small biopsy? That feels, more high-tech.
That's your custom paving job. It is high-tech, it's expensive, and it's a 2-stage process that might take 6, even 9 months to really mature. It gives you a better result than patch asphalt, for sure. But it's limited to the cartilage layer. It relies on a healthy, structurally sound foundation underneath.
Okay, which brings us to OCA.
Right. Osteochondral allograft. That's when the Department of Transportation, that's us, says the entire section of the road is compromised foundation and surface. We call in the biggest cranes, and we swap out a whole prefabricated bridge section, bone and cartilage included, with a biologically correct functioning unit.
That really frames the complexity, doesn't it, and the invasiveness. We're talking about swapping out major structural components.
Yeah, we are.
So when we talk about all these options, especially in our young, active patients, are we really selling them a permanent solution? Are we fixing them for good?
This is maybe the most important insight we have to convey, both to the patient and, to you as you're learning. Most biologic resurfacing procedures are, realistically, bridging procedures.
A bridge to what?
A bridge to an eventual total joint arthroplasty. We're doing them with the explicit goal of postponing or maybe even avoiding that prosthetic down the line. We want to improve their pain and function significantly, buying them decades of high activity time until they're older and, frankly, better candidates for a definitive replacement.
So we're extending the functional life of the joint.
Exactly. Not guaranteeing lifetime native joint function. That's a critical distinction.
Okay, so diving into the indications, when does that logistical headache become worthwhile? When do we actually bypass the simpler options and reach for that full prefabricated graft?
The clinical sweet spot is really defined by 2 things: size and complexity. First, size. We're typically talking about defects greater than 2 square centimeters.
Right.
And these lesions often come from high-impact trauma, localized osteocrosis, or very, very commonly, severe osteochondritis dissecans OCD. That's failed conservative management.
And complexity.
Second, complexity. We use it selectively in younger patients with degenerative arthrosis, where prosthetic replacement is it's absolutely non-negotiable. Think of a 25-year-old high-level athlete.
And we can't forget its role as the ultimate fallback, the revision option.
Exactly. Allografts are often the best revision options, sometimes even for smaller defects, especially after a failed prior procedure. And this leads us right to the single most compelling reason for choosing OCA over, say, ACI or microfracture.
Which is
The status of the subchondral bone.
that foundation of the road. It's so often the hidden, silent destroyer of these cartilage repair attempts.
It is the Achilles heel. We're looking for cases where you have significant subchondral bone loss, generally more than 5 to 10 millimeters of underlying deficiency. If you have a deep crater, even if you fill the cartilage on top, the biomechanical forces transmitting through that joint are just too great. The host bone can't rebuild adequate structural support quickly enough.
But why is that depth so critical, especially when we consider previous procedures? What did they do to the bone?
Because if that subchondral bone is compromised, any marrow-stimulating procedure like a microfracture is inherently compromised. The literature is quite clear on this. Some of these procedures can actually, detrimentally affect the integrity of the underlying bone architecture.
How so?
They often create this fibrous layer and they disrupt the necessary mechanical environment, which ironically can jeopardize a future, more complex revision cellular procedure. The allograft just bypasses this entire problem.
So we're not just treating the ice on the surface. The allograft uniquely restores the entire functional unit, the subchondral plate and the hyaline cartilage, giving you immediate, robust structural support.
That's the whole point. It restores the biomechanical structure immediately, which no other single-step procedure can do for these large defects. So when we target our best bet patients, we're looking for those localized, unipolar, meaning a single lesion non-degenerative, traumatic chondral lesions, or lesions from OCD or osteonecrosis.
I have a genuine question here then. If the bone involvement is so critical, why do we still, sometimes waste time on a microfracture for a large defect when we know the failure rate is high and it might even jeopardize a future definitive repair like OCA? Isn't that just delaying the inevitable?
That's a tough and a very real-world question. The answer is often resource-dependent. Microfracture is cheaper, it's minimally invasive, and it requires zero tissue procurement logistics.
So for a small lesion, a lower demand patient.
For a small, well-contained lesion in a lower demand patient, it can buy some time, it might work. But for a young, high-demand patient with a large defect, it's an inferior solution, and we counsel the patient knowing that it might, in fact, complicate future attempts. We prefer to go straight to OCA if the indications are clear and, the logistics allow for it.
Understood. Okay, so let's talk about contraindications, the absolute versus the relative ones. What are the non-negotiables that just stop us in our tracks?
The absolute no-go is simple. Active infection. We are transplanting tissue here. Introducing it into an infected site is medically indefensible and risks, potentially fatal complications.
And the other big one?
If the patient is clearly within the appropriate age and activity bracket for a primary total knee arthroplasty, a TKA, due to extensive degenerative disease, TKA is generally the better, more predictable long-term solution.
Okay, what about those conditions that make us pause? The relative contraindications that absolutely must be addressed before we even think about the transplant.
This list is crucial because these associated pathologies are the leading causes of allograft failure. Number 1, associated grade 3 or 4 fee-kissing lesions.
Bipolar disease.
Bipolar disease.
Yeah.
You've got severe damage on the opposing articular surface. You're placing this perfect high-tech surface on one side only for it to grind against a shredded, arthritic, or poorly healing surface on the other. That perfect surface won't stay perfect for long.
You're just setting up the new graft for immediate, high-friction, non-physiologic wear.
Precisely. Second, the structural mechanics of the knee have to be flawless. This means uncorrected malalignment, ligamentous instability like a torn ACL or PCL, or significant meniscal insufficiency.
Why?
Because the same mechanical forces that destroyed the original cartilage are certainly powerful enough to fragment the new graft. This is why we need those long alignment films if we even suspect malalignment. We have to confirm if a concurrent unloading osteotomy is necessary to correct the leg's axis.
Let's go back to the road analogy on this one. Why do we care so much about these adjacent pathologies?
Think of it this way. You've just installed that perfect, prefabricated bridge section, the fresh allograft. If the bridge supports, your menisci and ligaments are shot, or the entire riverbed, your alignment is shifting, that new section is going to be immediately subjected to excessive shear and compressive forces it was never designed to handle.
It needs a stable environment.
It needs a stable physiologic environment to survive the years of remodeling it's about to undergo. If you don't unload that graft in a varus knee, for example, you have basically guaranteed failure within a few years.
And then finally, the medical and systemic factors.
We have to exclude patients with inflammatory or crystal-induced arthropathies. conditions that fundamentally attack the joint lining. Significant immunosuppression is also a relative contraindication. It affects the host bone's ability to integrate the graft.
And lifestyle factors.
And we strictly advise against surgery in patients with altered bone metabolism. This comes from long-term steroid use or critically active smoking. Osseous integration is dependent on a healthy metabolic environment, which is just severely compromised by nicotine and chronic steroid use. We delay surgery until those issues are optimized.
All right, let's pivot now from the clinical side to the fundamental biology that actually makes this procedure work. The long-term success of OCA really rests on 3 biological pillars.
Okay, pillar 1, the hyaline cartilage surface. Pillar 2, the healing of the osseous base. And pillar 3, maintaining structural integrity during remodeling. Now, I'm guessing the key to that first pillar is viability.
Chondrocyte viability is the foundation of the foundation. Why? Because those cells, even though they're slow-moving, are responsible for maintaining the extracellular matrix.
The collagen and proteoglycans.
Exactly, the stuff that gives hyaline cartilage its incredible biomechanical properties. If the cells die, they stop maintaining the matrix. It's that simple.
And what happens structurally when those cells die off? It initiates a slow-motion catastrophe. Non-viable cartilage might look intact at first, but it's lost its essential biomechanical integrity. Without that cellular maintenance, the matrix just degrades. It leads to fibrillation. You get these deep clefts forming, and then eventual erosion over time. We need living, active cells to sustain the matrix and prevent the graft itself from degenerating.
Which brings us to the infamous fresh versus frozen debate. I mean, freezing would solve all our inventory and scheduling problems, yet fresh, refrigerated allografts are still the biological gold standard. Why are we still stuck in this narrow window?
Because freezing causes an unacceptable level of chondrocyte death when the cells are embedded in the matrix. It's a physical problem. We can successfully cryopreserve up to 90% of isolated chondrocytes in a lab dish, but here we're dealing with a dense, highly hydrated tissue.
Tell me more about that physical problem. Why does the matrix itself become the killer?
It's a combination of mechanical and chemical factors. First, that dense extracellular matrix physically prevents the uniform penetration of cryopreservative agents. And second, the matrix has an incredibly high water content. As the tissue cools, ice crystals form. But because the cooling rate is so unequal through that thick matrix, those crystals physically rupture the cell membranes.
So the resulting tissue is non-viable.
The non-viable tissue that results just doesn't have the long-term staying power. Current cryopreservation simply doesn't preserve an acceptable degree of viability for clinical use.
So we're racing against the clock. We can only use hypothermic storage at 4 degrees Celsius, not freezing, which is really just a temporary preservative measure.
Exactly. The storage window is the true operational headache. If the grafts are harvested within 24 hours and stored correctly, they maintain a reasonably high viability. Studies show close to 100% at 4 days. But the drop-off is aggressive.
Where's the cliff edge on that?
You see a really significant and sustained decline in survival after about 15 to 20 days. By 44 days, chondrocyte viability drops to approximately 67%, which is an unacceptable loss for a structure you want to last for decades. Mellon and his colleagues showed in primate models that grafts stored beyond 21 days underwent much more severe degenerative changes. It confirms this biological expiration date.
And here's the core conflict, right? The logistical catch-22. We need a minimum of 14 days just for safety screening.
That's the reality. For patient safety, to prevent infectious disease transmission, fresh allografts are held hypothermically for a minimum of 14 days for all the serologic and microbiologic testing. By the time we even get the call saying the tissue is clear, we're already halfway through the optimal biological window.
And the tissue banks are strict.
They strictly adhere to a maximum expiration of 42 days from procurement. So that gives us optimistically 28 days to match the tissue, schedule the patient, and perform the surgery. It's a very high-stakes timing game.
I remember the stress of trying to schedule a patient for their only viable date, knowing if we missed that one slot, they'd have to wait potentially months for the next matched tissue, maybe even miss their chance entirely because of a rare anatomical match.
It puts immense pressure on the OR schedule, on the surgeon, and on the patient. Now let's talk about the concept that allows this whole process to even exist without immune rejection, the immunology of cartilage.
Right, we don't need to match HLA antigens like we do for a kidney transplant. Why is that?
Articular cartilage is considered immunologically privileged. The chondrocytes are isolated by that dense avascular, lymphatic extracellular matrix. So the matrix acts as a biological shield. It physically protects the cells from the host's circulating immune cells and dramatically dampens the immune response.
But as you pointed out, the graft isn't purely cartilage. It has that thick, highly vascularized subchondral bone component.
And that osseous component is highly immunogenic. The surgical trauma, the presence of donor bone, it all stimulates a host inflammatory response. This reaction is directed primarily against the bone's non-viable marrow elements, the blood cells, the stem cells embedded in the trabeculae. And this reaction typically peaks between the second and third week after surgery.
Which explains why we're so fastidious about preparing the bone component in the OR.
Exactly. This inflammatory risk is why we insist on copious pulse lavage of the bone component just before we implant it. We're mechanically washing away those unbound antigenic proteins and non-viable marrow elements to minimize that initial intense inflammatory spike against the bone.
You want the immune system focused on remodeling, not attacking.
Precisely. We want to focus on remodeling the bone, not attacking the graft.
And the ultimate confirmation that this biological privilege actually works long-term is that famous Jamali finding.
Oh, it's a remarkable piece of long-term evidence. They performed a biopsy on a graft 29 years after it was transplanted. And by using gender markers, they confirmed that the actual donor cells, female chondrocytes, were still viable and still maintaining the matrix decades after being transplanted into a male recipient.
Wow.
It's the biological proof that fresh, viable allografts sustain the matrix and prevent long-term articular degeneration.
Okay, moving to the operational side, let's talk safety and planning. Before we even see the graft in the OR, we're relying completely on the procurement process.
Absolutely. We have to use AATB-accredited tissue banks that adhere to very stringent FDA guidelines. We need to confirm the graft harvest occurred within 24 hours of donor death, under strict aseptic conditions, and that processing was completed within 72 hours. This ensures the best initial quality and minimizes contamination risk.
Donor screening has become incredibly sophisticated over the past few decades to mitigate disease transmission. What are the key elements there?
The standard workup includes an extensive medical and social history review, plus mandatory serological titers for major viruses like HIV, hepatitis B, and C. But the key enhancement came in 2005.
What was that?
The mandate for nucleic acid testing, or NAT, for HIV-1 and HCV.
And NAT testing dramatically reduced the window period, didn't it?
Yes, exactly. Conventional tests look for antibodies or antigens, which take time to build up after an infection. NAT directly detects the viral genetic material itself, so it drastically shrinks that window where a donor could be infected but still test negative. The risk of viral transmission is already minute, something like 0.00004%, but these enhancements ensure maximal safety. That's paramount when you're dealing with fresh tissue.
And since we can't use cytotoxic cleansing because we need those chondrocytes to stay alive, we have to talk about the hidden danger, bacterial transmission.
It is the Achilles heel of fresh allografts. Processed frozen tissue can be sterilized, but fresh tissue cannot. The sources are very clear that bacterial transmission is a much greater concern here.
And the consequences can be devastating. I remember reading that case report of a fatal infection.
Yes. A rare but absolutely tragic case report detailed a fatal bacterial infection following a fresh OCA that was contaminated with Clostridium. This led to a huge investigation. And Malinin and his colleagues found that Clostridium contamination was present in 8.1% of all donors of musculoskeletal tissue.
Wait, 8.1%, 1 in 12 donors. That is a startlingly high number. It really underscores the severity of this risk.
It does. And the data shows the risk of Clostridium contamination increases with the amount of time that elapses between the donor's death and the allograft harvest. This is why that 24-hour harvest window is completely non-negotiable and why the mandatory 14-day hold for safety testing is so essential, even though it cuts into our precious 42-day viability clock.
It's a trade-off.
It's a necessary trade-off between biological viability and absolute patient safety.
Okay, let's pivot to the logistical nightmare for the surgical team, the preoperative templating phase. What's the essential diagnostic workup before we even send out the order?
High-quality imaging is mandatory. We need a magnetic resonance imaging, an MRI, to define the precise depth and size of the lesion, and that has to be coupled with weight-bearing X-rays to assess the overall mechanical axis. For you, the listener, if you look at figure 31.1a and b, you need those clear coronal and sagittal T2-weighted images to really assess the full osteochondral unit.
And if that standing film shows a mechanical axis deviation?
Then we require a long alignment film. We have to confirm whether that malalignment is significant enough to require a concomitant unloading osteotomy. If the mechanical environment is wrong, the graft fails. Full stop.
The most critical logistical step, though, has to be size matching. How precisely do we match the donor graft to the recipient defect, especially when you have to deal with magnification on the X-ray?
We use standard AP and lateral radiographs, but we have to place magnification markers like little radio-opaque spheres at the joint level. You can see this visually in Figure 31.2a through C. This allows us to calculate the real dimensions and correct for magnification error to ensure our templating is accurate.
And what's an acceptable match?
A match is considered acceptable if it's within plus or minus 2 millimeters of the recipient defect size.
2 millimeters sounds generous, but the anatomical variability must make this incredibly difficult, especially when you're crossing sexes.
It is extremely difficult. Knees are not cookie cutters. The curvature of a male femoral condyle, its height, its width, its depth, can be significantly different from a female donor. Even if the AP width is within that 2 millimeter window, you're matching a three-dimensional curvature.
So a mismatch can cause.
If the curvature mismatch is too great, you create edge loading and stress risers. And crucially, you should never accept a significantly smaller donor size for a large graft defect. That is a recipe for early mechanical failure and subsidence.
And this is where the operational chaos really comes in. We're dealing with a rapidly expiring product.
Yes. Because ideal matches are rare, especially for large lesions in specific anatomical zones, we find ourselves sending detailed measurements and imaging to multiple ATB-certified tissue banks at the same time. This process involves intense communication and often waiting weeks, maybe longer, for a compatible match.
And once that match is confirmed,
the clock is ticking faster than ever. We have to secure operating room time within that rapidly shrinking 42-day viability window. That surgery often takes precedence over other elective cases.
That is the resident takeaway right there.
Yeah.
The wait times, the scheduling pressure, the need to secure OR time instantly once the graft is cleared. It's a massive logistical juggling act that patients rarely appreciate until they're right in the middle of it.
All right, we've secured the graft, we're in the OR, the planning is done. We start with the patient positioned supine, tourniquet is inflated, and the knee is flexed to expose the condyles, usually somewhere between 70 and 100 degrees.
And the surgical workflow here is pretty rigid.
It has to be. The allograft is examined one last time. You can see that in Figure 31.3, confirming the anatomical fit and the quality, and then it's placed in a saline and antibiotic bath to begin cleansing. And we always start with a diagnostic arthroscopy.
Your final safety check.
It's our final safety check to make sure there are no surprises, no unseen kissing lesions, no loose bodies. And just to confirm, the patient is still an optimal candidate right before we make the big incision.
Exposure can be highly variable depending on the lesion's location. A classic medial femoral condyle lesion is one thing, but those posterior lesions are a whole different beast.
Exposure is the first technical hurdle. We typically use a medial or a lateral arthrotomy. But for lesions located far posteriorly, you need maximal knee flexion and potentially more extensile approaches.
Like what?
Proximal parapatellar mid-vastus or subvastus approaches to mobilize the patella and just allow you to see what you're doing. And while we really try to avoid it because of the morbidity, in complex, high-riding, or massive defects, a temporary tibial tubercle osteotomy can be used to dramatically enhance your exposure.
Let's focus on the workhorse technique then. The press-fit plug. The mega OTS approach.
This is optimal for those contained condylar lesions, usually between 15 and 35 millimeters in diameter. The big advantage is you get a stable, reliable press fit, often requiring no additional fixation. The primary disadvantage, though, is that you're sacrificing adjacent areas of perfectly healthy normal cartilage and bone to convert that irregularly shaped defect into a precise circular recipient site.
So we size the lesion, trying to minimize that collateral damage. You can see a sizing dowel in Figure 31.5 and then the guide wire insertion. You've said before, this is arguably the most important, least forgiving part of the whole process.
Absolutely non-negotiable. The guide wire has to be driven several centimeters into the center of the lesion, and it must be perpendicular to the curvature of the articular surface. Figure 31.6 shows this perfectly. If you drill that wire perpendicular to the floor of the knee, you're going to create a surface that's either proud or recessed when the plug goes in.
And that's immediate biomechanical failure.
Immediate failure. Perpendicularity to the articular surface curvature is everything.
Once that wire is set, we move to the two-step reaming process.
First, the cannulated scoring reamer. This just cuts through the articular cartilage along the circumference, creating a sharp edge but avoiding damage to the bone. You can see that in Figure 31.7a. Second, the cannulated coring drill removes the subchondral bone, creating the precise recipient site. It's shown in 31.7b and c. A proper preparation should expose healthy, bleeding host bone.
Let's dive deeper into this depth debate. Historically, deep plugs were the standard, but now we're seeing this trend toward much shallower bone cuts. What are the pros and cons of that?
We used to aim for 6 to 10 millimeters of overall depth, which meant about 3 to 8 millimeters of host bone prep. The current trend favors minimal bone thickness, sometimes only 3 to 6 millimeters of bone on the donor plug itself.
And the theory behind that?
The theoretical benefits are sound. You sacrifice less host bone, and crucially, you have a significantly smaller volume of non-viable donor bone that needs to be incorporated via remodeling. This should, in theory, decrease the overall remodeling time.
But logically, a shallower plug has to compromise the immediate rotational and shear stability, right? I mean, the circumferential press fit relies heavily on the depth of that cylinder.
That's the technical risk. By reducing the bone depth, you trade immediate stability for what is, for now, a theoretical faster integration. A shallow plug is much more sensitive to a slight depth mismatch or a poor press fit. It requires even more meticulous execution.
It's an area for future study, then.
It is a crucial area for future long-term studies. Are we creating more immediate subsidence by reducing the depth, or are we truly increasing longevity by decreasing the remodeling burden? We just don't know yet.
So the recipient site is prepared and measured. We turn to the allograft workstation to prepare the donor plug.
Meticulous execution is paramount. We secure the graft in the workstation, which you can see in Figure 31.9, after identifying the corresponding anatomical region on the donor condyle. We then core out the graft plug and use a specialized cutting guide to secure the articular side.
This is the moment with the oscillating saw and the rasp. Matching that thickness precisely seems incredibly unforgiving.
It is. Using the saw and rasp, as shown in Figure 31.2, we trim the graft to match the 4-quadrant depth measurements of the recipient site. Any thickness mismatch greater than 1 millimeter means failure. A cowed graft causes impingement and rapid wear. A countersunk graft creates a lip that traps fluid and increases shear forces. It has to be perfectly flush.
Then comes that essential immunological step, the pulse lavage.
Yes, before the plug goes in, it receives copious pulse lavage to wash away those remaining donor marrow elements and antigenic proteins. This minimizes the risk of the host immune system reacting violently to the bone. And finally, the graft is inserted by hand and gently tamped into place. You can see the sequence in Figure 31.4 view.
Gently is the key word.
Absolutely. The host bone needs to be clean, and the insertion must be gentle. We know from studies that excessive impact loading causes chondrocyte death.
Okay, can we quickly address the shell graft technique? This is for those anatomical areas where the plug technique just doesn't work.
Right. Shell grafts are mandatory for areas like the tibial plateau, the patella, or the trochlea, where a cylindrical plug would either sacrifice too much normal tissue or the geometry is just prohibitive. The advantage is minimizing tissue sacrifice. The disadvantage is extreme technical difficulty and poor inherent stability.
So they almost always need fixation.
They almost always require rigid fixation with compression screws or bioabsorbable devices.
It sounds like a complex reconstruction. I've heard of using foil templates from suture packs to handcraft a shell, leaving only 4 or 5 millimeters of bone.
It is absolutely a complex reconstruction. It requires meticulous manual handcrafting, often mimicking the cuts we'd make during a unicompartmental knee arthroplasty, but with far greater precision needed to match the native curvature perfectly. And those fixation devices have to be absolutely recessed to avoid damaging the opposing articular surface.
Okay, the graft is seated and stable. We move to the immediate postoperative period. The medication protocol is highly specific, particularly when it comes to pain management.
We usually continue IV antibiotics for 24 hours. But the most critical medication instruction is the strict avoidance of non-steroidal anti-inflammatory drugs and SASs for the first 6 to 8 weeks.
That's a common instruction across orthopedics, right? It's all about maximizing that bone-to-bone healing and not inhibiting the osteoblasts.
Correct. The bony integration of that allograft base to the host bone is our immediate priority. For DVT prophylaxis, low-dose aspirin is standard unless there's a contraindication.
Range of motion begins quickly, using a CPM machine or a stationary bike. But weight bearing seems highly dependent on the stability we achieved in the OR.
Very dependent. For a small, inherently stable press-fit dowel, we might allow immediate toe-touch weight bearing for 6 weeks. However, for a large, unstable plug, and almost universally for any tibiofemoral shell graft, we are much more conservative, meaning non-weight bearing. A strict non-weight bearing regimen for 6 to 8 weeks to protect that osseous integration. Patellofemoral grafts are a bit different. They can often bear weight, but only with a brace locked in extension to protect the graft from shear forces during knee flexion.
And the rehab progression is slow, avoiding open chain exercises entirely for months.
The focus is isometric and closed chain exercises. Cycling is our favorite, starting around 4 weeks. We avoid the high forces associated with open chain leg extensions. And return to sport or recreation is highly variable, anywhere from 4.5 months to over a year. We have to caution patients, especially those with large grafts, against high-impact, repetitive loading indefinitely.
Okay, now let's synthesize the data. We've gone through all this technical and logistical complexity. Does the data actually back up this effort? What do the long-term results show for survivorship?
The results are quite strong, and they do justify the procedure for these large defects. Shalal and colleagues did a systematic review, looked at 644 knees. The mean defect size was large, 6.3 square centimeters. They reported high patient satisfaction, 86%, but the frank failure rate was 18%.
So what are the long-term survival rates? If we tell a 20-year-old this is a bridging procedure, how long is that bridge, really?
The longevity is good, but location matters immensely. For the femoral condyle, survivorship was reported between 74% and 76% at 15 years. That's a robust number for a biologic procedure.
But it also means 1 in 4 have failed by 15 years.
It does, and that has to influence our informed consent process, particularly when we're counseling that 20-year-old. We have to be very clear that a second procedure down the line is a real possibility.
And what about that location disparity? Why do tibial plateau allografts perform so poorly?
The outcomes are pretty dire for tibial plateau grafts. Only 46% survival at 20 years. And this is likely due to the biomechanics. The tibial plateau is subjected to significantly higher shear forces and less contained compressive loading compared to the femoral condyle. Plus, the underlying bone stock in the tibia tends to be less dense, which complicates the integration process.
We also have to emphasize the difference between unipolar and bipolar disease in the outcomes.
This is a clear lesson from the data. Unipolar femoral grafts, single lesions, do significantly better. Chu and his group reported 84% good to excellent results for unipolar grafts.
And bipolar.
Contrast that with bipolar resurfacing, which only achieved 50% good or excellent results in the same series. Merrick's group reported only 64.1% survivorship for bipolar grafts at 5 years. When you're dealing with two opposing damaged surfaces, you dramatically lower your odds because that new graft surface is constantly articulating against a damaged or poorly supported host surface.
But the longevity for large unipolar grafts is still remarkable. Raz and his colleagues reported 59% survivorship at 25 years for unipolar grafts over 3 centimeters. That really validates the decades-long bridge premise.
It does. Now, before we address complications, let's revisit that salvage scenario. Primary OCA versus OCA after a failed marrow stimulation procedure.
Grassatelli and his group compared primary versus secondary OCA. What did they find about the clinical improvement versus the complications?
It was interesting. They found similar clinical score improvements in both groups. So patients felt better regardless of whether the OCA was their first surgery or their second. However, the critical difference was the complication rate. The primary transplantation group had significantly fewer reoperations, 11 out of 46 compared to 20 out of 46 in the secondary group.
So the takeaway is?
While OCA can salvage a failed microfracture, the primary approach offers a much smoother, less complication-ridden path for the patient.
Now the downside, the allograft-specific complications. What is the most common mode of long-term failure, and why does it happen?
The most common cause of long-term failure is mechanical failure of the bone component, graft fragmentation or collapse. And to understand why, you need to understand the process of creeping substitution.
Can you define that process for the listener?
Creeping substitution is fundamentally a race between the host and the allograft bone. When we transplant that bone, it's non-viable. It's essentially a scaffold. The host body sends in osteoclasts to chew away the dead donor bone, and at the same time, osteoblasts lay down new, viable host bone. This complete replacement process takes years, often 18 to 24 months, sometimes longer, to fully incorporate a deep plug.
So if the mechanical loads, the stresses of walking and running, exceed the strength of that partially incorporated non-viable scaffold bone, what happens?
Microfracture, collapse, and fragmentation. The graft bone is simply weaker than native bone during that substitution phase. If the non-viable bony trabeculae can't withstand the stresses, they collapse, and that results in graft failure. Garrett noted that all 10 failures in his series were due to fragmentation. It's a race that the body's remodeling process has to win against the high loads of the knee joint.
We also see a degree of inevitable subsidence, don't we?
Yes. Many grafts will subside 1 to 3 millimeters initially, just due to settling and the early remodeling phase. Some reports show up to 30% subsiding 4 to 5 millimeters. As long as frank collapse is avoided, this subsidence is often asymptomatic, but it's a unique feature of incorporating a non-viable bony scaffold.
And the worst-case scenario, deep infection.
It is rare, but it is devastating. Deep infection requires immediate aggressive management, and the standard recommendation is prompt removal of the allograft. Because the donor bone is largely non-viable at first, it acts as a perfect nidus for surgical infection, and you simply cannot reliably clear that infection while that large piece of non-viable tissue remains in place.
And finally, that low-grade immune reaction. Not full-blown rejection, but a persistent inflammation.
Right. Although histologic rejection, where the entire graft is destroyed, is very rare, we do see a low-grade inflammatory reaction. Some patients develop anti-human leukocyte antigen, or HLA antibodies, which may contribute to persistent low-grade discomfort or synovitis. The theory is that larger grafts present more antigenic material, increasing this low-grade immunogenicity. But the clinical significance for the average patient is usually pretty minimal.
Okay, let's bring this deep dive to a close. For you, the orthopedic resident or the clinician deciding on treatment, the key advantages of osteochondral allograft transplantation are clear. No donor site morbidity, the ability to address these massive defects, and the reliable restoration of viable hyaline cartilage backed by structural bone.
But those advantages are massively constrained by the operational reality. Significant supply issues, the extreme cost, those complex logistics, and that critical, unforgiving 42-day viability window.
Still, despite those hurdles, for large defects, particularly in high-activity individuals after a failed prior procedure, where you know that subchondral bone is compromised, OCA remains the superior and often necessary choice.
And the research continues to try and break that 42-day limit. There's some exciting work being done on advanced storage media, like the Missouri Osteochondral Allograft Preservation System, or MOPS, proton supplementation, and growth factor-enriched media. If we can push viability to 60 or 90 days, we solve our single biggest logistical problem overnight.
So let's end on a provocative thought, connecting our technical debate back to our long-term failure mechanism.
Indeed. We know that fragmentation and collapse of the osseous component is the most common mode of failure, and it's all dependent on that long, multi-year race of creeping substitution. We also know the current trend is towards using much shallower bone plugs, those 3 to 6 millimeter thick grafts, to theoretically speed up that remodeling process.
The question is, how will this trend affect our long-term survival statistics at the 10 or 15-year mark?
By reducing the volume of non-viable donor bone that needs to be replaced, we should theoretically reduce the risk of late collapse. But are we compromising the immediate stability and press fit by cutting the plug so thin? Does less bone volume to remodel necessarily lead to fewer failures, or does it lead to earlier subsidence under shear load? We're making a critical trade-off in the OR, and only the next generation of long-term studies tracking these shallow grafts will tell us if we made the right choice.
That's the next frontier of OCA research.